Hi there, it's Archie back for the ADHD Care Podcast. Hope you're all doing well. I want to take time to say Happy New Year to all our listeners out there. Today we have a special guest joining us today. We've got Dr. William Dobson, who is an adult psychiatrist whose career spans over 25 years, specializing in ADHD. And also he's authored, written so many articles and also book chapters, and now is in the process of actually writing his own book, which is entitled Treating ADHD. His insight into ADHD is fascinating. I've attended so many conferences over the last few years whereby Dr. Dobson was there giving his talks and presentations, which was well received by so many professionals. And I'm glad that we managed to connect and arrange for him to come onto our ADHD Care Podcast episode today. So let's bring him onto the call.
Nice to meet you.
Nice to meet you, Dr. Dobson. Yeah, it's been a very long time. I've been trying to organize a time to sit down and speak to you and meet with you, actually, and bring you onto this podcast. Thanks to Melissa, she's the one that kind of got us together, which is absolutely amazing.
Yeah,
And yeah, how are you doing?
I'm doing just fine, just fine. I'm at home recuperating from surgery, so
Right.
I'm bored to death because I can't leave the house. But
Yeah,
um,
yeah. Oh,
I
I
like,
wish you
I,
I wish you a
so
speedy recovery.
thank you. I hope I have it. I'm a very impatient person. I'm ready to go driving again and
All
going
right.
back.
Oh dear.
So uh,
So, yeah. Whereabouts in the country in the US are you based at the moment?
I'm in Denver. It's about two-thirds of the way across. It's in the middle of nowhere. It's 600 miles to the next big city. So
Wow. Wow. Yeah.
that's a blessing, though. I have
Yeah.
everything I want here in Denver,
Yeah.
uh, and none of the craziness of the rest of the country.
I can just imagine that. Yeah. It sounds quite
Uh,
remote and very peaceful.
yeah, it is. It's what we
Yeah.
call a flyover town, where people
Right.
going from the East Coast to the West Coast fly over.
Of course. Right.
Don't really notice we're here.
Yeah. So, obviously, there's this common theme that's brought us together, which is ADHD. It's something
Mhm.
I'm very passionate about, and I know you are as well, which is why I've dedicated this podcast purely to bring professionals like yourself to come on and talk about all things ADHD. Um,
Uh-huh.
and I just wanted to get your take on a few things. I know I've thrown you some questions in an email in the last few weeks, so I thought maybe we could just delve into some of those things that we've been discussing on our email.
Okay,
Is that all right with you?
that's great.
Excellent.
That's
All
great.
right. All right. So I just wanted to spend time just to start with, just to maybe focus around emotional dysregulation and rejection
Okay.
sensitivity dysphoria, which I know that's one of your passionate. Those areas are one of your kind of passionate areas.
Yeah, yeah. I was the first one to write about it
Of
back in
Yeah,
2010.
really.
So yeah, so it's a concept that's sort of identified with me because for 8 to 10 years I was the only person saying anything about it.
Mm,
So
yeah. And look at us now. Fast forward to 15 years later.
yeah,
It's something, and I can see that it's definitely a need that needs to be highlighted and discussed because it plays a key part in ADHD, as you know.
oh, it
Um,
does tremendously.
yeah, yeah, but it's not listed as part of the diagnostic criteria, which is something
Not
that
at all.
I
In
feel.
fact, if you look in the literature, the usual researchers not only have ignored it,
Mm,
they've almost suppressed it. It's very, very difficult to get
mm,
anything published.
yeah. Um, for our listeners, do you mind just explaining to us what emotional dysregulation is?
It goes all the way back to the definition of what ADHD is. Our current diagnostic criteria are an antiquated mess. They're based on 6 to 12-year-old elementary school age white boys. That's it. We don't have any criteria that are established on people over the age of 12. And so people with ADHD um, really there's no diagnostic criteria that are universally agreed upon. The people in Europe for the last 10 years have really been pushing to broaden the diagnostic criteria to include the things that adults have to deal with. And a big one for them is what they called emotional dysregulation, which is a fancified term that really just means that people with ADHD have trouble controlling the expression of their own emotional lives. And it has a couple of major problems. One is just the intensity of emotions. People with ADHD, their emotions are much more intense, much more passionate than the general population. Some people with ADHD have less ability to deal with emotions. They are easily overwhelmed. Their ability to cope with strong emotions is poor. And so consequently, emotions tend to be expressed much more intensely, much more suddenly. People lose their temper, have flash temper and things like that. And then to make matters worse, most people with ADHD have what the guys at Harvard call dyslexithymia, which is, again, at Harvard, they put everything into Greek. Dyslexithymia means using the wrong word for feelings. You know, we control our emotions by how we think about them and how we name them. So most people with ADHD refer to their major emotional problem as being anxiety, when it's not. When somebody comes in and says, "Doc, I am so anxious," my first response is, "Tell me more about your baseless, apprehensive fear." That's the definition of anxiety, that for no reason, baseless, I have the feeling that something awful is just about to happen. 4 out of 5 people will look at me and go, "What? You know, I didn't say I was afraid." I said, "Okay, well, just drop that label of anxiety. Tell me what you feel, what you're experiencing." 4 times out of 5, what I hear is, "I'm just constantly going inside. My brain never slows down. I'm worried about how I come across to other people. I can't sleep at night because I sit there and I replay the day and everything I've ever regretted in my life." He says, "Oh, so what you're talking about is what it's physically like to still be hyper-aroused, hyperactive on the inside." So unless you can make that distinction between true, psychiatrically defined anxiety and hyperarousal and inability to control the intense emotions you have, you're going to end up trying to treat the wrong thing. Now, the average adult with ADHD has seen 2.3 clinicians, gotten diagnosed with mixed anxiety and depression. On average, they have had 6.2 failed antidepressant trials before they get their diagnosis of ADHD. So it really does slow down by about 7 to 10 years a person getting a diagnosis of ADHD. So recognizing emotions and being able to describe them accurately to the clinician gets you treatment, much better treatment that works much earlier in the process. So that's been one. Go ahead.
Yeah. So I'm just thinking about a few things as you were talking there. One, obviously, some of the onus is on the clinician to be able to distinguish between the two, isn't it?
Mm-hmm.
And I also think about when we think about autism, because I'm a clinician as well. There's what we call state and trait anxiety. So there's anxiety
Yes.
that you generally has as a trait, part of your
It's
neurodevelopmental profile, and then you
part
got
of
in
who you
state.
are.
Exactly.
Yeah.
So that's kind of a little bit what you're describing there. And I've seen
Yeah.
a lot of people coming through our doors as well, being misdiagnosed with things like anxiety, as you said,
Yeah.
who might actually just have ADHD or emotional dysregulation is what we're describing.
Right.
And clearly you can see why they haven't responded well to traditional treatments for anxiety, for example, CBT or the anti-anxiety medications. So yeah, I'll just let you carry on.
No. So again, it's as you point out, most clinicians have never been trained on ADHD at all. In the United States, when you look at the training of adult psychiatrists, 93% of the training programs never mention ADHD ever in 4 years of training. So the people go to an adult psychiatrist hoping they'll help them. 93% of them know less than the patient does. And so that's why that's the first really big hurdle that anybody has to go through, and that is to find an expert who really knows ADHD. And those people, because the training is just not out there, most of those people have had to learn what they know on their own and from their patients. Now, I had 2 residencies, neither one of which mentioned ADHD even once. So just about everything I know I've learned from reading, but mostly because I have very patient patients who guided me along and told me when I had it wrong. So again, that's the first big hurdle, is finding somebody who will slow down, take the time, and listen for ADHD. The biggest problem is most people have never gotten any training on it, and so they only see the things they were trained to see. And that really slows people down. I mean, after somebody's seen 2.3 clinicians and not gotten any progress, a lot just give up. They don't go to see that third person who knows what they're doing. So that's a huge impediment toward getting a right diagnosis and at least a chance at treatment. So going back one topic, in Europe, back in 2018, a group headed by Sandra Coy in Amsterdam put together an updated guideline on adult ADHD. And in that, they added another 4th core feature of ADHD in adults. And that was emotional dysregulation. And that was 40 years in coming. Should have been added 40 years ago. And so just about everybody with ADHD has impairing levels of difficulty with managing their own internal emotional life and its expression. It's a huge impairment. In my practice, about 1/3 of my patients said, that is my biggest problem. I found ways around my academic and work performance, but my butt just gets kicked by the fact that I can't control my own emotions. And there's been very little done. In fact, if you look at the research, the problem there is that an inability to control emotions is part of every diagnosis in the DSM or the ICD-10 in Europe.
Yep.
And so it's not, it's what they call transdiagnostic. It's found in everything. And so the researchers are looking at difficulty with emotional control everywhere. Whereas really what we need to do is focus on how it presents in ADHD in particular, because it's different there. One, it has a treatment. I'm sorry.
Is emotional dysregulation part of executive functioning?
Okay. I have to label myself as thinking that the whole subject of executive function deficit theory is nonsense. It's been around for 20 years. It's dominated the field. It has never once produced a therapy that had benefit, not once. And they've never had a research that showed that more than half of people with ADHD have an executive function deficit. You can't base a theory of an entire condition like ADHD on something that less than half the people have. And we can quickly get rid of the whole concept of executive function deficit with one question. I'll ask it to you, put you on the spot. Look back over your entire life. If you've been able to get engaged and stay engaged with literally any task of your life, have you ever found anything you could not do?
If I ever got engaged in something that I was passionate about.
Yeah.
So are you trying to say it's more interest-based, isn't it, from what you're trying to say? So
yes.
Yeah. So interest-driven.
What I call situational.
Yeah.
Just about everybody will
Yeah.
sort of hem and haw the way you did, but ultimately come around to, no, if I could get engaged,
Mm,
I could do pretty much anything.
mm,
The, the impairments of ADHD are tied to the situation. If you can get in the zone, you can do anything. So that just completely changes our understanding of what ADHD is. It also says if you can do anything in the right circumstances, you do not have executive function deficits. The whole theory is wrong. And it blows away with one question based on the experience of everybody with ADHD, that when you get interested, once you get engaged, stand back, you'll do great. That's the key and the definition of ADHD. People with ADHD are inconsistent in their performance, but in a very
yeah.
consistent way.
Mm.
So that's a whole nother presentation.
I was just about to say, I was literally about to come back at you there with a few things because I know
Uh,
even Professor Barkley speaks about executive dysfunction, and I know we're talking about emotional dysregulation here, but we cover things like organization, time management, self-regulation, which links to with the emotions that we're describing today.
right.
So just because one isn't able to perform something on a consistent basis, are you saying that that therefore means that it's not an executive dysfunction on their part,
Right.
just because you're able to do it in
Right.
other situations?
So again, the term that you're just beginning to hear percolate up in not so much the research writing, but elsewhere, is that people with ADHD are omnipotential. They literally are potentially can do everything, anything. It's just you have to learn how your nervous system works. Um, Everybody thinks that the um, treatment recommendations for the treatment of ADHD is medication and behavior management or executive function. And point of fact, none of the non-medication based therapies have been able to show any benefit at all for the now four core features of ADHD: attention, inattention, impulsivity, hyperarousal, emotional dysregulation. Behavior management, behavior-based treatments don't work at all. And in fact, if you go back to the very first guidelines here in the United States, the American Academy of Child and Adolescent Psychiatry back in 2007 dropped their recommendation for multimodal therapy. Recommendation number 10 says if the medications work well enough, you can stop right there. Because in good conscience, we cannot recommend therapies that we know do not work. But the researcher guys are still out there pushing multimodal therapy, even though 52 different variations on that in a row have all failed to show any benefit at all. Now, this older, we had benefit. Oh, they'd help executive function deficits, but it didn't help the four things that define ADHD. It didn't touch them. So
Yeah.
a lot of it, what's out there is that right now, our researchers are totally inflexible. You and I are normal people. If we try something once, maybe twice, and it's a total failure, what do? We drop back and say, I am missing something huge and fundamental about what's going on. I need to rethink this. We need to talk it out. We need to search for what we're missing.
So
Not the field of ADHD.
So if we think about the treatment for emotional dysregulation, so you wouldn't be advocating for like some sort of talking type psychological therapy to address understanding emotions, a bit like what you do with cognitive behavior therapy. In
No,
this case, for ADHD, yeah.
that still has benefit for emotional dysregulation, but largely after the fact. Usually, people with ADHD get surprised by their own emotions. They pop out. They blurt things out. They suddenly lose their temper. And so consequently, all of those classes and things like that, or behavior management, dialectical behavioral therapy and stuff like that, they've got those skills, but they don't have time to stop, recognize what's going on. I'm about to lose my temper, and I remember what my teacher said I needed. No, they're blindsided. it's too late. And they've said or done something they immediately want back, but it's too late. So cognitive behavioral, dialectical behavioral, that stuff does help a lot. The trouble is, it's in the retrospect. It's 10 minutes from now, after the damage is already done. So again, it's not this dichotomy of do you do medication, do you do therapy? No, you need both. Every time you need both. It's this false dichotomy that's always plagued ADHD.
I think the how they introduce sort of non-medication type therapies based on how severe your symptoms are. So if you're categorized as the mild, maybe on the moderate scale of your symptoms, they would introduce behavioral therapy first, and the medication could be introduced after. Because if you think about the children's guidelines, that's kind of what they base it on, isn't it? They wouldn't introduce medication first. They introduce parental strategies, modifications, and things as first line. What would you say about, from a young person's point of view, parenting strategies and parental therapy? Is that something you would recommend, or would you, again, is it a combination of medication and those other things?
Well, one of the few interventions that they have shown works very well is parent training therapy. And it's called by different names, but basically making better parents. And that greatly lowers the tension in the family, the outbursts, and things like that. The thing is, that's, again, changing the environment of the child, not changing the child. The child functions better, but he still has exactly the same neurologic problems to deal with. So it helps, and it's a short-term solace, but nothing's really happening with the child. I mean, that's the problem with all of these behavior management, is what they do is they change the structure. They provide more structure around the child. But there have been dozens of therapies that have shown if you take the child out of that structure, take them out in the hall, it's gone. It's not there anymore. So they say, oh, no, this had a great deal of benefit. What they don't tell you is it doesn't last. In the MTA study, 9 months of 2 hours every day, treatment for the kids, training for the parents, what they call maximum dose behavior management. Added nothing at all to medication. And when they came back 3 months later, there was no indication that it had ever occurred. Because that is bound to having somebody else there constantly structuring your life, helping you work through things, nipping emotional outbursts in the bud so they don't get expressed. But that's not a way for an adult to go through life with a keeper at their elbow all the time. So that's why it only makes sense to start with medication, because the medication's always there. They are tremendously effective. So what we're talking about is non-medication-based therapies that are marginally effective too late versus medications, which are probably the most effective treatments in all of medicine. We measure how well any drug, any surgical procedure, anything in medicine, how well it works with a measure called effect size. And it's exactly what it says. It's a very complex mathematical, statistical determination, but it's basically asking the question of how well does this work as compared to all the other things I might have tried. Just about everything in medicine comes in between 0.4, which is barely detectable, but consistently detectable benefit, and 1, which is very robust. When you have somebody who knows what they're doing with the medications, they come in at 1.8. They're that much better than anything else in medicine. The second line medications, the alpha agonists, come in at 1.3. Even our, guys who sitting on the benches, they're still better than anything else. Why forfeit the most powerful treatments in medicine? And it's against this false dichotomy. Oh, well, these are little kids, they can't take medication, so we're going to do something that doesn't work with a hoot because we're protecting them for these awful medications. It's nonsense. I mean, if you said, kid comes in and, has a strep throat, I mean, this could, proceed to meningitis very easily. And we say, well, we're going to treat this with a behavior technique, and we're going to have them cough better and stuff like that, because we're going to hold off on the antibiotics. You go, this is crazy. You're trying to kill my kid. Mm. So again, people do things in ADHD they would never get away with anywhere else.
Do you think it's because of the stigma around the medication and just which is still exists? Yeah.
No. I mean, anywhere, if you look at a rock anywhere in the world of ADHD, you're going to find stigma and shame. Those two things are everywhere in everything. And having ADHD is not for sissies. It is a tough life that many people with ADHD contend with alone. So yeah, the stigma getting in your way, and mostly just ignorance. Again, most doctors are not trained on ADHD, so what little they know, they learned in some lay magazine, and it's wrong. It's certainly out of date. Most parents don't know anything about it. Most teachers don't know anything about it. So it's, again, you have to go through several clinicians before you find one where ADHD even comes on the radar screen.
Mm. Yeah. And that, sadly, that's still the case, even over here in the UK, everywhere across the world, when you speak to people, what you just said there about the lack of understanding, people seeing a professional, ADHD not being picked up, being misdiagnosed, even if it's picked up, they're not accessing the right treatment at the right time, which leads me to my next point about treatment, because you got your upcoming book that you're writing on ADHD treatment, and kind of trying to highlight some of these gaps that we've kind of touched on a bit during our discussion. Do you want to tell us a bit more about the book itself?
Sure. I'm not a researcher. I practiced. I saw patients for 45 years. And when I started trying to learn about ADHD several decades ago, I discovered that what I was reading in the literature, in the books, and I read everything I could get my hands on at the time, did not match at all what I was hearing from the patients. It was like they were looking at two different groups. And so, being a practitioner, if what I hear in reality doesn't match with what I read about, then what I read about is wrong. I'll go with patients every time. They know what they're doing. They've lived it every moment of their lives. And so it was in living and talking with and having my patients guide me that I started coming up with the things that where the major holes were in the field of ADHD. The first one was what it is. How do you know you got ADHD? In fact, our second chapter is not on the diagnosis of ADHD because our diagnostic criteria just really suck. They're really just awful. We don't have, 45 years after it was recognized officially that ADHD persisted into adulthood, we don't have adult criteria, not even close. And probably worse than that, we have no knowledge at all on women with ADHD. All we know is that women with ADHD present in a totally different way. So that's a huge hole that needed to be filled. Second one was the medications. There was no methodology out there that would teach somebody how to choose a medication, how to, educate the patient about it, how to fine tune it so they got 100% of what medication had to offer and no side effects. And then the third one was, since none of the talking therapies were effective, how did you take this new understanding of ADHD and turn it and apply it to the real world to help people deal with their nervous system? Those are the three things that are missing. And so that's what the book is about, trying to fill in the holes, the gaping holes. Diagnosis and treatment are pretty big gaping holes in any medical condition. So that's what the book is about.
Hmm. And why do you think there's been a lack of a comprehensive treatment manual for ADHD? Despite how ADHD is so prevalent,
Yeah.
and we know how it impacts.
Well, because we've relied on researchers.
Mm,
Think about who people are that do research. First of all, most of them have doctorates in something other than medicine. They've never treated a patient in their lives. They don't know the medications. Second thing is, even if you do have somebody in research, the current paradigm is you get a big group of people, you impose a certain treatment to be tested on those people. And the first thing you do once you get your data is you combine it and then report statistics of a mean with standard deviations. And what that does is it completely erases individuality. One of the axioms in medicine, in ADHD medicine, that is always true is that if you know one person with ADHD, you know one person with ADHD. Everybody with ADHD has to be treated as a unique individual. Well, researchers are looking at averages. They don't see individuals. In fact, they do everything they can to erase individuality so that they're not even aware that when you fine-tune medication, it has to be to that unique individual. Third thing is researchers don't like things that can't be measured. And emotions, since we're here to talk about that, emotions can't be measured. If I'm angry, well, how angry am I? If my feelings have been hurt, how rejected do I feel? How do you put a number up? You can't. And the other thing is, they don't like things that aren't always there. Emotional dysregulation is something that comes and goes according to what's happening in your life. And so it's not always there. When it is there, they can't measure it. And the third big problem is people with ADHD are terribly embarrassed and shamed by their inability to control their emotions. Everybody calls them a head case or they're immature or something like that. So the people with ADHD don't like talking about their emotions. They don't want to let anybody know that from time to time they're completely out of control. You're not really an adult if you can't control your emotions. And so these are things that just, our way of doing research right now does not fit the paradigm of ADHD in the slightest. Researchers are never going to be able to come up with treatment for all of those reasons. And they don't acknowledge that, their vaunted, scientific method, evidence-based treatment, all that other stuff. That's all really good. Trouble is you can't have it in ADHD for the reasons I just listed. So that's why ADHD, the field of ADHD, has been paralyzed for the last 25 years. Another question I ask people, especially knowledgeable people like yourself, look back over the last 25 years, basically the 21st century. Can you name one new thing that has come into the field in those 25 years that has actually worked?
I know we've had different types of, medication, I can think. There's been more medication.
Medication's been around since the 1950s, not new.
I mean, like the different options that we now have compared to 25 years ago as well.
Yeah, those are variations in delivery systems, and again, not new.
Okay, but certainly in psychiatry in general, or just in general,
ADHD.
In ADHD, there's been controversial things coming on the objective testing, for example, but how effective is that? Is that we've got QB test and TOVA and all of these tools. Coaching therapy.
Well, that's been around since about 1990.
Okay, all right. So there isn't. I think to give you the answer, there isn't.
That's my point. Is the field of ADHD has not made progress in at least 25 years.
No,
it's paralyzed because the researchers can't admit that their method is very difficult to apply to something like ADHD. I
Mm.
mean, that's what separates mental health research from everything else, is that it's subjective, it's individualized, it's hard to measure. So you get people, I mean, people who I respect tremendously, like Steve Farrell, who's as big in Europe as he is in the United States. But he says hyperfocus does not exist. Why? Because he can't measure it. And if he can't measure it and prove it's there, then it's not that he can't measure it. He says it doesn't exist. And Steve has a whole list of things that because he can't measure it, he says don't exist. By the way, emotional dysregulation and rejection sensitivity dysphoria are on that list. But the thing is that we all know that in the field of mental health, there are lots of things that everybody talks about that we can't prove exists. The unconscious, for instance. Can you prove that your unconscious mind exists? No. And yet we use that term all the time and everybody knows what it means. But that's been around since Freud, for 125 years. And yet researchers say because we can't measure it, it does not exist. I mean, they're very narcissistic people. The world revolves around them and their method. So, I mean, that's been the big impediment is it's people who actually live with ADHD and value lived experience. For instance, I could tell a patient, look, everybody with ADHD, it seems, is much brighter than the general population. Average IQ is 123 to 130, all the IQ necessary to do anything. People with ADHD are world-class problem solvers. They think out of the box and they come up with answers that nobody else would come up with. And I could tell a patient that all day long, but they wouldn't believe it from me because all they look at is the multiple failures in their life that brought them in to see me. So that's why it's important we go back to the patient's experience, that if the situation is right, they can do anything. They have to have that lived experience where they know personally that that is true. I can't prove it to them. They have to know, yes, I have seen that with my own eyes, or that hyperfocus exists because I've had it, I've lived it hundreds of times in my life. So it's a different level of validity. Right now, we need to, traditional research has shot its wad and come up with nothing. So now it has to be a time of using a different way of looking at ADHD that looks at personal validity. You know it's right because you've lived it. So getting back to rejection sensitivity dysphoria, people in their guts know it's right because it's happened to them. And the descriptions that I've been putting out there, they go, that's me. I thought I was alone with this. I thought I was the only one that had this trouble. And now I see millions of people share this problem with me. So it is lived experience. I know this is true and it's always true because I've seen it with my own eyes.
So if you were to influence the guidelines to some degree, what would be helpful? Because obviously in the UK we have guidelines, as you know, on ADHD for children, young people, adults. That's again based on research, isn't it? So I agree with you on the point about
by the way, the ones on late adolescents, adults, and the elderly have never once been validated. Never once. We have got it. It's the best we can do. But research can't show that they actually describe people with ADHD. And in point of fact, they miss virtually all women. So just because you have guidelines don't mean that they're real.
Yeah.
It's the best you can do with bad information.
That's it. And I suppose for anyone new coming into the ADHD field, picking up the guidelines, and some of them might follow it as it is, like as if it's the Bible, that's where, when you think about medication, it says A, B, C, D. That's how you prescribe. But I was going to ask you about this question actually. You can combine stimulants, non-stimulants based on the individual, because some people find
Right.
certain non-stimulants might work with their emotional dysregulation alongside their stimulant. What's your experience, particularly on the medication side of things? Because I've heard this before. I've got a patient of mine. She's on guanfacine, but she's
Yeah.
also on methylphenidate, a combination of both. And she
Okay.
finds, being a woman as well, again, menstrual cycle and all of that, the non-stimulants tends to help her address the emotional side of things compared to what the
Right.
stimulants would do. Again, that's obviously personal to her. But what's your general overview and what's your opinion on that?
Okay. The stimulants are wonderful drugs. I mean, they're dramatically effective. In fact, I tell my patients, we're going to try both molecules, see which stimulant molecules, to see which one you respond best with. And we're not going to stop until we get a wow level of response. Wow, where have you been all my life? This is life-changing. Don't settle for anything less than life-changing. But 70% of people, when they try the first stimulant, go, eh? That's a third of people don't respond or don't tolerate the first stimulant they try. Stimulants do one thing spectacularly well, and that is if you're already engaged with something, it keeps you from being distracted. That's it. That's all. Helps a little bit with impulse control. That rather than being blindsided by what you're going to say and do, you have the same 2 seconds that everybody else does. See it coming up, label what it is, play out, oh, if I do this, that's going to happen. Oh, I don't want that to happen. I'm going to redirect this somewhere else. And with practice, all of that can easily happen in 2 seconds. Whereas before, they'd just been blindsided, it would come from thought to action instantly. So that's what the stimulants do. What they don't do, they don't help with impulsivity that much, and they really don't help with hyperactivity that much. Now, sometimes when the dose of a stimulant gets way high, especially with kids, you get the zombie effect, where that paradoxical effect, where a stimulant puts somebody to sleep. And all that means is just the dose is too high. So, the 3 questions I ask to somebody about whether I'm going to consider an alpha-2 agonist like guanfacine. Again, I'm big on asking questions because it has to come from the patient's experience. So, first one is I ask about RSD. Question there is, look back over your entire life. Have you always been much more sensitive than anybody else you know for rejection, teasing, criticism, or your own perception that you have failed or fallen short? Virtually everybody with ADHD will answer that positively. And then there'll be a bell-shaped curve. There are going to be some people say, yes, it's devastating. And the other people, yeah, it occurs, but it's an annoyance. It doesn't bother me that much. But a third of people say, that's the most impairing part of my ADHD. So it's a big deal. The rejection sensitivity responds to the alpha agonist robustly, life-changing, about 60% of the time, which is about the same as any mental health medication. So that's a home run 60% of the time. For the other 40%, the monoamine oxidase inhibitors work real well, but they're a pain to take, but they work. Second thing I ask is, at any one time in your life, just pick a time, how many completely separate, simultaneous lines of thought do you have going on in your head? Most people, nobody's ever asked them that. So they have to stop and think, well, usually have at least 3, maybe 5 things going on simultaneously. Well, that in and of itself is tremendously distracting. The alpha agonist, when you find one that works, that number goes down to 1, and it's the one that you want. So that really lowers the stimulation level. And also, down the line, it gives better attention span. Third question is, tell me about your sleep. Tell me about a typical night's sleep. Usually what it starts with is, well, doc, I'm a night owl. I know that if I got into bed at 10:30 or 11, I'm not going to go to sleep because I can't turn my brain and body off. My mind is just constantly worrying. Average length of the time I lie there is about 2 hours. And when I do go to sleep, I toss, I turn, I wake up to every noise in the house, and the whole thing starts again. That's the hyperarousal component of ADHD. It's just in adolescence, it's up until adolescence, it's constantly just the hyperactive little boys. In adolescence, it goes underground and presents as internal, mental, emotional hyperarousal. And the fourth thing I ask is look back over your entire life. Can you remember a period of time longer than about 5 minutes and not drug-induced back in your wild and woolly youth in which you have been both mentally and physically at peace? Now, peace is not exactly a good scientific word, but it's the right word in this case. Most people get a good hearty laugh and say, "Are you kidding me?" No, not ever. My mind is always going, it's always doing something. So most people end up answering all four of those questions positively. And those are the four things that the alpha agonists do extremely well that the stimulants don't. And really, people describe it as putting on emotional armor. If they still see the things that have wounded them terribly going on out there all the time, but now it doesn't wound them. They don't go off into an RSD episode. Their thoughts go down to one thought rather than a dozen. They are able to shut their brain off, that hyperarousal, shut it off and sleep naturally. This is not putting people to sleep. It's getting rid of the impediments to sleep so that people can sleep naturally. And so they don't go through the next day sleep deprived. And the fourth thing is, again, it slows down that hyperarousal so that from time to time, a person can just sit there and be peaceful. And I really want to emphasize this is not creating an artificial state. It's removing the hyperarousal of ADHD so that you're back to the way everybody else does. In fact, that's usually what the question is. You mean this is how everybody else lives? I've been going through this unnecessarily? So that's who I'd use the alpha agonist for.
Would you use that in combination with a stimulant or?
Always. No.
Right.
Each one has something totally different to you to offer. In fact, when a person comes in and says, rejection sensitivity dysphoria is the thing that impairs me, I'll start with the alpha agonist and think about doing the stimulants later. Right? Again, you always have to go with where the patient is. If the patient comes in and says, well, I'm anxious and depressed, and you go, oh, no, what you really have is ADHD. The patient has a feeling you're not listening to me. And again, people with ADHD are used to that and they're pretty fed up with it. And you have to show the patient that you're listening carefully, you're understanding them in a deep and personal way before they'll ever trust you on anything else. So,
yeah. Now that we're touching on rejection sensitive dysphoria, I was just going to get your take on that because I know that's one area that you've spoken about so loudly and so eloquently out there. You mentioned there about someone's perceived rejection. Would that not be something that stems from maybe their early childhood or something that happened in their life at some point that gave them this core belief of any sort of situation that might arise, which actually might not be a rejection, but to them it might then trigger something else that's happened in their life, which is causing them to react in the way that they react, which therefore, would you not think about some sort of psychological talking cognitive behavioral therapy might also be helpful to address the underlying core issue in that situation?
Again, it's not one or the other. It's both. We talked earlier about the fact that having an ADHD nervous system and going through a neurotypical world is incredibly damaging. There's a good article by Michael Jelenic that shows that by the time a child is in the third grade, they have already heard 20,000 additional negative or corrective messages in school alone. 20,000 additional messages by the third grade. Also, that 70% of third graders with ADHD do not have a friend, not a single one, mostly because of their behavior issues. So ADHD, all by itself, is traumatic. And for us, the third phase of ADHD is to go back and review your life now with the new information you have about what was really going on, and to look at how that tremendously impacted your sense of who you are and how it expresses itself in all of that negative thinking that goes on in your head that nobody else sees. Did I do something to make somebody mad at me? What will somebody think of me if I do this? Nobody really likes who I really am, so I have to wear a mask all the time. I have to be something false in order to fit in. And so consequently, since nobody knows the real me, they can't love the real me. And those are things that are huge impediments to a happy life. And they can really only be addressed once a person knows how that got there, and basically have their emotions not erased, but basically giving them an equal break, that their emotional regulation is the same as everybody else. So you have to address three things. Emotional dysregulation, which is a neurologic phenomenon, and in people with ADHD, it responds beautifully to the stimulant medications. There's several studies out there now that if you take adults with impairing emotional dysregulation, 60% of them, but 2/3, it will go away entirely while they're on stimulant medications. Well, that's tremendous. That's better response to medication than anything else in mental health. Tremendously effective. Now, still means 40% don't have it go away, but still, a 60% home run rate in any park is pretty good. I'm not sure what the equivalent would be for cricket, but in baseball, that's what it is.
So if you are a clinician, listen to what we're talking about, and maybe you're quite new to ADHD, or you're not really fully aware of ADHD, and because obviously what we're describing, some of this might be confused with mood disorders.
Absolutely.
How would you differentiate a patient presenting there with some of the emotional dysregulation and rejection sensitivity traits between a mood disorder and ADHD in this case?
Okay. You go back to the basics. What defines all mood disorders? Mood disorders, the abnormal mood comes out of the blue for no reason. The moods, and I quote here the DSM, the moods have taken on a life of their own, separate from the events of the person's life and outside of their conscious will and control. So they just come out of nowhere, untriggered. They come on gradually over a period of weeks to months. By definition, they must stay unchanged for at least 2 weeks, and usually it's multiple months. And then when they resolve, as most of them do, they resolve very slowly over weeks to months. That's a mood disorder. That's anxiety, depression, bipolar, all of it. Look at the moods of ADHD. If you have somebody with ADHD, they'll say, no, my mood shifts are triggered every time. Other people may not see it, but every time I can see what caused my mood to change. And the mood change matched the source of the trigger. Technical term is it was congruent. If bad things happen, I feel bad. If good things happen, I feel good. The change is instantaneous. If something happens, the trigger, mood shifts 100%. Twinkling of an eye. For people with ADHD, their moods are not sustained. even a bad experience of rejection sensitivity will only last about 24 hours. Usually the person goes to sleep and wakes up without the episode. So when you look at the basic features of a mood disorder and ADHD, they're exactly the opposite. ADHD moods are triggered, instantaneous. They match the nature of the trigger. They are short in duration. In other words, for people with ADHD, their moods are normal moods in every way, except their intensity, and they are extremely intense. So important thing, just going back to the basics of do I have a mood disorder at all, it's usually very clear. And there are people, of course, who won the negative genetic lottery and have ADHD and depression, ADHD and bipolar, ADHD and substance use disorder, ADHD and borderline, that sort of thing. And that's where you really have to go to a specialist, a true specialist. But for the vast majority of people, it's very clear how they are different. They're totally different. Does that make sense?
Yeah. Yeah.
Okay.
You just answered my next question there, because I was going to say you can actually have both depression and ADHD,
Oh, yeah.
and how do you differentiate between the two? And yeah,
70% of people with ADHD will have another active axis 1 major psychiatric diagnosis. It's the rule, not the exception. So even though I specialized in adult ADHD, I had a complete breadth of practice because people brought in every other psychiatric disorder. It's just I was comfortable with treating both conditions. For instance, 40% of people with bipolar disorder also have ADHD. 40%, that's a lot. So, it's right now we're still working on getting enough people to do the basics. And that's what the book is about. You can take somebody who wants to know, and the book will take them step by step to being the most competent person within 100 kilometers. It's not a textbook, it's a manual.
Yeah. What's the title of the book, of the manual?
Recognition and treatment of ADHD. And the reason we use the word recognition instead of diagnosis is that, after you're 16 years old, 14 years old, our diagnostic criteria don't work. In fact, under 16 years old, it doesn't work at all for women. So all it's really going to pick up is hyperactive little boys. That's all it picks up. They used to say, well, ADHD went away in adolescence. What nonsense. Everybody agrees that ADHD is genetic and neurologic. Can you name one other condition that's genetic and neurologic that goes away with age? No. On your 18th birthday, you don't get this beautifully wrapped box and you open it up. Oh, just what I always wanted, a new nervous system. But that's what they believed. And a lot of people still believe.
Yeah.
It's nonsense.
That's where the term "you grow out of it" came from.
Right.
Do you remember? Yeah. You would just grow out of it when you're older. Yeah.
Yeah. Rather than if a person who was 25 met the hyperactive elementary school age child criteria, that person would be totally impaired. They would not be able to function in adult life. So those were the only adults they were picking up, were these almost disabled severe ADHD patients, rather than adults are different from children. They have to do different things. The demands are different. Their lives are much more complex, etc. But again, it's wishful thinking. ADHD has been full of wishful thinking. Oh, since we don't know anything that works, we'll just hope that it goes away with time. What other neurologic condition goes away with time? Parkinson's, multiple sclerosis, seizures? No. Medicine in general is the treatment of chronic conditions. Once you have a condition, it's yours forever. high blood pressure, heart attack, stroke, whatever. But the only thing we can really treat are bacterial infections. That's it. We don't cure anything. So that's why I said, this whole notion of spending 50 years waiting for it to go away, they should have known right from the beginning that was ridiculous. But everybody signed on to that. ADHD is full of a lot of groupthink that's just on the surface, absolute nonsense.
Do you think the understanding of the nervous system, uh, raising awareness around that would help people? Because if they think, oh, you just grow out of it, or you can learn to cope with it and you go away, all of that, understanding that it's to do with the brain, that it's not something you're born with. It's to do with your brain and how your chemicals in your brain work. It's not
Right.
going to miraculously just disappear after like a certain age, is it?
Yeah. Well, again, a lot of people think that fixing the blame and fixing the problem are the same thing. And so for decades, ADHD was understood as being bad parents or bad children or both. In fact, that's still what the American FDA, Food and Drug Administration, thinks about things like oppositional defiant disorder. They say ODD doesn't exist. It's just bad kids and bad parenting. Well, let them come sit in my waiting room in the afternoon after school, and they'd be convinced otherwise.
Yeah.
But again, the people who control the money for drug research, for behavioral research and stuff like that are huge impediments to getting anything done because of their erroneous beliefs. Again, it's a very mean-spirited way of looking at it. Let's blame these people who are having trouble, and because it's their fault, we don't have to do anything for them. I mean, that's just mean-spirited. Not only do you see it in the American FDA, you see it in the schools all the time. Kids with ADHD are said, oh, they're slow. They don't try hard enough, that sort of thing. So that's why it's important to me to emphasize that all of the non-medication based therapies, in other words, here's your problem, you need to try harder, they don't work. And so expecting them to work in school when they didn't work in the hands of the people who developed these techniques, again, nonsense. So again, that blaming is so very important because it determines whether or not a person gets assistance from the people that are supposed to be there to assist them. They're doctors, they're teachers, they're administrators, etc. If you believe this is just a bad, misbehaving kid, that kid gets no help at all.
I think that's the difficulty, that when you look at ADHD to some degree, you can see the behavioral element to it, which makes people focus on that more than anything else. It's like, okay, they
Yeah.
choose, if they make it feel like the young person's choosing to behave in that way, or the inconsistency that comes with it. One minute they're able to perform,
No.
but the next minute they're not. Going back to what you're saying about the
It
interest-based.
seems willful. If
Mm,
you can do it once, then
yeah,
you're expected to do it every time.
yeah. So it's either you can't or you can. That's how they
Right.
look at it. You can't
Right.
be like 1 minute you can do it, the next minute you can't.
Right.
And it goes back
But
to
if you did it once before and you're not doing it now, you're being disobedient,
yeah,
lazy, willful, etc. You get blamed rather than I don't understand what's going on.
yeah,
And how can I get back to that phase, that situation in which this kid's the brightest kid in my class?
yes. Or look at the
So,
environment itself that's made them perform well the first
yeah,
time that they did it. What is it that was,
one was structured, one was not.
yeah. So there's all these other factors to look at externally rather
Yeah,
than looking at the young person and expect them to change.
yeah,
And this is the battle I always have with schools,
yeah,
where they might use a behavioral policy to address a certain issue that's happened, rather than looking at the situation and environment and trying to change that.
precisely.
Yeah.
But the thing is, the point I wanted to make is the place where it all goes bad is when the observer blames the child or blames the adult for not trying hard enough. One of the very first books that addressed it is still in print. Is You Mean I'm Not Lazy, Crazy, or Stupid by Kitty Kelly and her last name's Raimondo. I mean, it's a classic. But those are the explanations that people with ADHD are offered about why they're struggling. Well, you're lazy. You haven't tried hard enough. You're crazy. You're just completely out of control, or you're stupid. Again, this was originally called minimal brain damage back in the 40s and 50s. Rather than these are good, hardworking people, very bright, that have to deal with a nervous system that's different from the standard nervous system. So that's why I go back and say, look, we really got off the rails right from the get-go by saying ADHD is a disorder. Now, it's a second nervous system. If you can do anything at all, everything, under the right circumstances, that's not a disorder. That's our lack of recognition that we're dealing with a nervous system that works perfectly well. These people can do anything. It's just we haven't shown them how to do that consistently. So, and that again, the book goes into that in great detail. That's all of chapter 2. And again, it's called The Recognition of ADHD. It's what does ADHD look like and what explains what's going on underneath. Diagnostic criteria we have are pretty much useless, except for elementary school age hyperactive white boys. That's what it's based on. That's what it's useful for. Misses everything else. I just did an evaluation of an 11-year-old girl. I get people calling me from all over the world because they had multiple treatment failures. And when you give her the standard Vanderbilt screener, nothing. She endorses one. Yes, she's severely impaired by her ADHD. And it's just, again, because she was a young female and not hyperactive, diagnostic criteria were totally negative. But one mild symptom. But so if you know what to look with, she was rip-roaring ADHD. So, we have to be able to recognize ADHD first. Because usually the problem is ADHD never comes on the clinician's radar screen, doesn't come on the parent's radar screen. Because the name is so terrible.
Yeah.
Attention is not deficit, it's excessive. Most people are not hyperactive. They're internally tremendously aroused, but you don't see it on the outside. And a disorder, you can't call something a disorder that brings so many positives and for people who can do anything. So ADHD is really a second nervous system that works on its own totally different set of principles, actions, techniques, etc., and doesn't work at all on the importance and rewards that the neurotypical nervous system works on. Again, I'm big on questions. Here's another question. Go ahead.
If you were to sum up and redefine ADHD in your own words, how would you define it? Give it a title. What would you call it?
ADHD is a genetic, neurologic, brain-based condition in which people who have it cannot make use of the ways that everybody else organize and manage their lives. Neurotypical people use importance and they use rewards and consequences. A reward for doing the task, a consequence if you don't. One of the questions I ask people is, look back over your entire life. Can you remember one time ever in your life in which the importance of the task all by itself ever once helped you at all, helped you get engaged with the task, stick with the task all the way to the payoff? Or has the importance of the task, just been a nag? How would you answer that? I'm putting you on the spot. You can edit this out if you want.
Yeah, we know a lot of ADHD people that they thrive from the last minute, like meeting
Urgency.
urgency. That's it.
Yeah.
So when something's due, pretty much like in the next day or so, that's
Mhm.
when the adrenaline kicks in and all of that stuff. Yeah, and I'm sure they'll be able to come up with a few examples around that. Do they really want to do it? Probably not. The interest is not there, but they know they
Yeah.
can do it.
Well, the thing is, their importance is useless to them. Most people say, I know what's important. I actually want to have done this, but I can't get started. Procrastination, I cannot get engaged. And so what that means is all of the techniques that they've been taught in a standard school system by their parents, by their coaches, you do this because it's important, or you do this because there's a reward at the end, doesn't work. People with ADHD like rewards, don't like consequences. They know what's important. It's just the three things that organize and motivate everybody else are not usable. The 5 ways in which a person with ADHD can get engaged and get access to their abilities are the big one you've already mentioned: interest. In the psychological literature, they use the word fascination. It's the same thing. If you're interested in something, comes easily. In fact, it's hard to tear you away from it. Second one is challenge or competition. If somebody says, oh, you can't do that, if the person's response is, oh, yeah, whatever that task was, they're going to have it mastered by the end of work today. Third one, novelty. Is it new? Is it problem solving? Is it creative? Being able to music or art or something like that. People with ADHD are world-class problem solvers. And that's what we pay the big bucks for out in the world of work, is not the grunt who's going to go and implement the solution. We pay the big bucks for the person who figures out what to do. So if we can get the ADHD out of the way, most people with ADHD just shoot up the ladder because they now know what they're good at. The fourth one is the one you mentioned, urgency. And it's sort of the equivalent for people with ADHD of importance. Neurotypical people use importance. ADHD people use urgency in the same way. And the fifth one is something else you've already mentioned: passion. What do I deeply care about? What gives my life purpose and meaning? And a lot of people say, well, isn't that important? Yeah, it is sort of important, but what really makes it work is the emotional investment. That's what makes it work. So it's interest, challenge, novelty, urgency, passion. That's it. So when a person with ADHD is presented with an important but boring task, they know their ability to get engaged with that has to be in 5 different categories. And so it narrows it down about what really worked for my nervous system. And I'm going to stop trying to do it because of either interest or, even worse, secondhand importance. My teacher thinks this is important. My boss thinks this is important. In fact, important enough, he's willing to pay me to do it for him. So again, it's a totally new approach to the world based on what a person with ADHD has seen in their life experience works for them. We
I
always go
realize
back to life experience. Yes.
I realized you didn't mention consequences there, or did you? No.
Yeah. Rewards and consequences are just different sides of the
Yeah.
same coin.
Right. Okay. I get you. Right. Yeah. Yeah. That's absolutely true. From experience, I've clearly seen that, and I think I'll describe them as, they're more sprinters than long distance runners.
Yeah.
They'll sprint to the final line, and they will definitely sprint and aim to be the first, coming out the first.
Yeah.
Um,
Can
but
I, can I add, I'm sorry,
yeah, yeah.
finish the thought.
Um, yeah, go on. I'll let you go.
Okay. Oh, I'm sorry. Something popped into my head. There's one nuance I want to add, and that is that when we talk about ADHD, the medications and stuff like that, almost always we're talking in terms of performance, performing better, more efficiency in life. But your nervous system is a package deal. It's everything that you are. Everything that you experience, everything you think, everything you feel comes from your nervous system. And so ADHD affects everything because it's neurologic. So think about what you are like when you're good and thoroughly bored. In other words, the exact opposite of being interested and engaged. Think about that. If you're like most people, first thing you say is, I never allow myself to get bored. Being bored is almost physically painful. I hate it. But sometimes you can't avoid it. When that happens, what do you like? Well, I've got no energy. I'm just a blob. I just want to sit there, and I'm irritable. I just don't want anybody to come near me. I don't want anybody to mess with me. Leave me alone. And my mood is just really black. I don't like myself. I don't like you. Nothing in my future sounds good. I'm just a bleh. I hate life. But luckily, everybody with ADHD has had thousands of experiences, again, back to experience, that tells them, if I can get engaged and get started in something, it's all different. I've got lots of energy. I'm enthusiastic. I'm gregarious. My mood is positive. Let's go do something new and fun and interesting. So this ability to get in the zone, to get engaged, is useful every moment of your life, not just when you have a task to do, but when you want to adjust your mood and your energy level. In fact, that ability to manage your nervous system affects everything. And we shouldn't just limit it to performance issues.
Mm.
So it's a big, big concept that just keeps getting bigger.
In the case of someone taking medication, out of those 5 things that you talked about, how does medication allow you to be much more interested, engaged, the novelty, the urgency, the passion? Does it enhance all of those things?
Doesn't. Everybody has the hope that I'm going to take a pill and all of my problems are going to be solved. And about a month and a half, 2 months out, it doesn't. I mean, it does what it's supposed to. You now can focus and stay focused and things like that. But it doesn't help you get focused. And so people get disappointed because their expectations weren't met. And they stop taking the medication saying, oh, I tried the medications, but it didn't work. Medications did what they were supposed to. The stimulants, once you got engaged, kept you from being distracted. It did exactly what it was supposed to, so that, your attention span was the same as everybody else's. The alpha agonists help you get rid of the hyperactivity that was constantly driving you and keeping you sleep deprived and all that other stuff, and very vulnerable to these RSD episodes where you just drop off a cliff. That doesn't occur anymore. And so you're not constantly being overwhelmed by your own emotions. So when you get the medications right, you have the same opportunity as everybody else. You're no better, no worse, but you're not having to deal with all that mischievous. Then, in order for life to change, you have to learn about your unique nervous system and how to manage it. And again, it's fairly simple. What we conceptualized is that people with ADHD were given the wrong owner's manual back in preschool. The owner's manual about how to get their personal nervous system to work at its optimal level of benefit. And they were given one for an importance-based nervous system that never had a single chance in the world of working. And so they failed hundreds of thousands of times. And they blamed themselves, and everybody else blamed them for failing. Now, you didn't try hard enough, rather than the techniques we gave you didn't have a chance of working. So the second piece is to write your own owner's manual, not based on what you can't do, but what your experience tells you gets you in the zone, gets you access to your abilities, and allows you to be superhuman and to be able to have your nervous system show up as the situation demands. That's utterly life-changing. It's still not enough. Because the third piece we've already discussed is to go back and review your life and how you got to this point, now with very special knowledge about how it all happened, what the implications were, why you still have that awful negative voice going on in your head, telling you what a schmuck you are all the time. And you basically have to go back and rework your understanding of your life story. Then you got 3 pieces in order. You can't leave out a piece. That makes sense?
Yeah, and that element might need a professional to help you through all.
Absolutely.
Yeah.
So you need somebody with prescriptive authority to do the first piece, and somebody who understands ADHD on a deep level, a coach, good therapist, to do parts 2 and 3. So again, it's not medication or therapy, it's medication and cognitive therapy, psychoeducation, and some trauma-oriented psychotherapy. Then you got it.
For anyone newly diagnosed with ADHD, what would you offer them as key advice?
Okay. No matter how you think about medications, about a third of people out there taking a medication for something, it's just not part of their life experience. Their family doesn't go to doctors. They don't take medications. Now they'll take all sorts of supplements and vitamins and stuff like that don't work in the slightest. So they'll, go on a special diet that doesn't work in the slightest or something like that. That's what their expectation is. That's what their culture tells them. So whatever you were born with, whatever you grew up with, at least consider the medications to get you in the game on a level playing field. Give them a try. Suspend judgment. Give them a try. See what they can do for you. And then make your decision. You make decisions on the basis of knowledge rather than habit or culture. See what they can do for you. Most people, when they see what they can do with the help of somebody who knows what they're doing with the medication, and they see that it is life-changing and that life just got a whole bunch easier, most will continue with the medication. The second thing that has to be confronted is what we call the antibiotic fantasy. We have strep throat, and somebody gives us ampicillin. I'm going to take this medication for X number of weeks. I'm going to be cured, and I won't need to take medication anymore. You have to that's there in everybody. That is everybody's hope, that I'm going to take the medication, and the medication alone is going to solve everything. That needs to be nipped in the bud in the first session. That is why half of people do not fill the third prescription. We lose half of people because we do not confront that fantasy. So then you have to do the psychoeducation to let them know what they're up against. And the fact that they have to write their own personal owner's manual based upon their experience of what works, not what fails. And then the third part is, many people consider it optional, I don't, is you have to go back and understand what happened. Understand your life and the effect that your nervous system has had on every aspect of your life. And rework the sense of who you are, who you always had the potential of being. When you do that, then you get a marvelous outcome. You get happy people. But until then, if you just think medication's going to do it, you're going to be terribly disappointed.
I'm just sitting there thinking a lot of my clients do exactly that. The looking back and go, tracking their life in terms of their childhood and how they got to where they got to. But sometimes they can regret at the same time. They can look at it and go, if I
Oh,
only had this
absolutely.
diagnosis. So how helpful is it looking back at that point when you get the diagnosis?
It's tremendously helpful. Um, the thing I tell people is in 45 years of practice, I have never once had a patient say to me, gee, I'm glad I waited that extra decade before I tried medication. Everybody, everybody has this tremendous sense of regret. What would my life have been like if I had known this in the second grade? My life would be totally different. And so there's a period of mourning, of frank mourning for all the wasted time, all the pain that they had to go through, all the disrupted relationships, the loneliness, the guilt, the shame, all the stuff that they went through totally unnecessarily. That has to be worked through. Otherwise, they'll carry it with them forever. Now, the nice thing is that the outcome of that is what I call the times wasting response. That people, once they mourn what might have been, they say to themselves, well, I don't know how much time I've still got left, but I am not going to lead it with regret. And you got big on questions.
Mm. I'm,
I'm sorry.
I've a couple of questions before I let you go. First of all, what was it? I should have asked you right at the beginning, really. But what was it that brought you to this ADHD field? Obviously, being a psychiatrist yourself, tracking all the way back. Is it 25 years now? You've been in this field for ADHD.
I started my first ADHD clinic in my second year of psychiatry residency back in 1978. So I've always been interested in ADHD. Most people with ADHD are the world's best patients. They're bright, they're funny as can be. They do so magnificently well. If they're actually identified and given good treatment, they do very, very well because they have so much going for them. And because they were being ignored. So I just found them fascinating. Still do. Because, I mean, they're great people to work with. Very, very, very little in medicine and psychiatry can you say, I can turn this person's life around this afternoon by making the right diagnosis and helping them access the abilities they already have.
Yeah.
So I don't personally have ADHD, but I found that most of my friends did. I just really like ADHD folks because they're so much fun.
Yeah. But in terms of like when you look around your other adult psychiatrist colleagues, do you feel you have a part to play in terms of like trying to educate them as well? Because obviously they see other patients that might possibly have ADHD.
That's why I'm writing this book, is to help if a clinician wants to know, and most don't, but if they want to know, at least they'll have something now that will help them learn it. This is what I had to learn on my own. It took me 45 years to know from experience what worked and what didn't. And I had my patients to teach me. My patients are truly patient people. They're very patient with me. And when I got it wrong, they said, oh, no, it's really this. They were very kind to me. But that's where I learned what I know. And so now I'm trying to take everything I learned over 45 years and put it in a book that's accessible to both clinicians and to patients
When are we
about what
expected?
works.
When do we
Yes.
expect this book to be released?
I hope about Thanksgiving, mid-November next year. I hope.
Okay. Well, you mean
Um,
2025? Isn't this year?
2025. Yeah,
Okay.
the book is written. It's
Okay.
with editors right now. And the big problem we have is we've got too much information. So we actually, just this weekend, decided to delete the last three chapters just to shorten the book. The last three chapters are really for practicing psychiatrists to treat um, people who have ADHD plus conditions. And that's well beyond what the average practitioner wants to know. So that'll be volume two.
Okay. Yeah. I look forward
Uh,
to getting a copy of that at some point once
you
it's
know,
out.
we tried to set the price point to also be very accessible to everybody. Um, the criteria we used, again, we're very basic people. And the book had to cost what a person would pay for a lunch at a nice restaurant. We figured
Okay.
that was, something that was accessible to just about everybody. So we have to fit the book into that price point. Because if you look at books on ADHD, they're all over 80 pounds, $100. And most people pick up, look at the price, and put it right back down. So we want this book to be used and to be accessible. So, just fundamental things like that.
Yeah. So yeah, that's something for our listeners to look out for. So it's mainly geared towards practicing clinicians.
That's what's pitched to, because the lack of clinicians is the stubborn clog in the pipe. We've got lots of people who know that they're ADHD, and we got a lot of good treatments. The problem is we don't have physicians to diagnose, medicate, and direct people to therapies that work. That has always been the big obstacle. And so that's who the book is written to. But it's written um, in a way that the average layperson can read it and understand it in the first read. Everybody thinks that physicians are super smart people, so it has to be written in this super difficult scientific language. Now, physicians are just like everybody else. Um, and one of my favorite quotes is from Albert Einstein, that the scientist who can't explain what he's doing to a 12-year-old is a charlatan. So
Yeah.
that's
Just keep.
that's
Yeah.
uh,
So for what was I going to ask? Yeah, I was just going to ask about because obviously I came across you at the International Conference on ADHD in over in the US. Not the one last year, the year before that. Did you come to the one just gone in
no, I
California in
didn't.
Anaheim?
I was
Yeah,
not.
yeah.
I was sick, so I couldn't go.
Of course, no, I understand. But you came to the one before that, didn't you? The one I
Yes,
think
and
that was
I'm going to
Baltimore.
the next one in Kansas City in
Oh,
November.
of course. All
In
right,
fact,
and I look forward
I'm
to.
okay. I'm the keynote speaker, so I got to show
Well,
up.
oh, wow, that's breaking news there for our listeners. So usually that's kept as a secret up until like 2 months before, but this is good news to hear and refreshing. Certainly, we've had the keynote
I look
speaker
forward to
before.
meeting you in person.
Absolutely. Before I let you go, any sort of one takeaway message you'd like for our listeners to remember from today's discussion?
Oh wow. Um, you start by asking yourself that first question. If I've been able to get engaged and stay engaged, is there anything that I have not been able to do? Because nobody's ever asked people that. People ask, where are all your impairments? Where have you failed? And it just brings people down. For people to have hope that life can be better, they have to see that there are special conditions in which everything goes right. And it's not just their performance, but their mood's great, their energy's great, their outlook on life is great. That there's real reason to be very hopeful. Because until a person is able to be hopeful in spite of all the failures and frustrations they have, they're not going to do anything. Sigmund Freud said the very first step in any therapy is what he called the restoration of morale. Hopeless patients don't get well. So you have to give them realistic, not any promises or anything. The person has to know from their lived experience that things can be dramatically different. That's the first step. So they have to ask and answer that first question. And then remind themselves of that the problem is not with me, it's that I've been trying to use the wrong owner's manual. People have misdirected me my entire life. That's where I'd start.
That's something I often hear, is the being misunderstood or misheard, no one advocating for me, all of that. That's certainly what the narrative most people come through and say. Do you feel ADHD is is overdiagnosed or underdiagnosed at this stage?
Everybody has said just because suddenly we became aware of how common ADHD was, most people want to deny its existence and its importance. And so I said, well, he'll grow out of it. We don't have to do anything. It's really not that important. It's not that sort of people who basically just said, we're not going to pay attention to this. But it doesn't exist. It's overdiagnosed, which means all these diagnoses really don't exist. Therefore, I don't have to get off my ass and do anything. And all of these are excuses for not helping. So the answer is there have been 6 studies done by the U.S. federal government alone that have shown that we still miss 2 out of 3 diagnoses. Somebody's sitting there in front of a competent therapist, and the diagnosis is missed 2 out of 3 times. We grossly under-recognize ADHD.
Why is that? Why is it missed?
Ignorance. Yeah, it's been very difficult for people to break away from the childhood diagnostic criteria since they came about. Basically, the criteria we have right now came in the Diagnostic and Statistical Manual 3 in 1980. So we're out here at 45 years of using these old, useless criteria and still can't break away from, or just recognize how limited those criteria are and that we need to start over again. It's this tremendous impediment to thinking new thoughts, especially within the research community. And, if normal people like you and me failed every time for 45 years, you would think somebody would say, we're missing something huge and fundamental, and we need to go searching for what that is. Nobody in the research community has broken away from that groupthink to do so. Or if they did, the people in the groupthink have kept them from publishing.
If I think about the rating scales that we use for adults, obviously the ASRS, for example, the BARS, the Barclay Adult ADHD Rating Scale, the CARS, all of them kind of stem from the childhood rating scales, though, don't they? So I can see why another clinician might be trying to get the client to score out that rating scale, and for them not to score, because they're more focused on childhood symptoms, pretty much, if you think about it. They're not tapping into the RSDs and the emotional dysregulations and all of that.
The sleep disturbances, emotional disturbances, the tremendous vulnerability that women have to the level of estrogen. They just don't even know that that's connected. So again, they're stuck using criteria that have never once been validated beyond the age of 14. Not once. And they know that these are not valid criteria for adults, and they still insist on using them. The field of ADHD medicine is paralyzed. There's been nothing new that worked in the last quarter century. And that's one of my grandiose hopes, that this book will inject some new thinking. That's my hope. Maybe it's grandiose. Maybe nobody will ever buy it. Um,
Mm.
it is my hope that if the book comes out in November, um, doctors will get 7 or 8 copies of it as Christmas gifts, and they'll take the hint.
So
Yeah.
your hope will be to have a. I'm interested to read the book now. Certainly for me, if I'm having clients that I'm trying to assess and I'm asking them to fill out these rating scales that we just talked about there, and sometimes yes, helpful to some degree, sometimes misleading. You're hoping that your book, with the way that you've written it and asking the questions and all of that, might be much more, beneficial for us as clinicians, rather than using a rating scale that's not really fully evaluated in
Exactly.
adults. Right,
100%. Yes.
right.
And ask things that really matter. Like,
Mm.
well, if you can get engaged, have you ever found anything you couldn't do? That picks up people with ADHD. Remember the 18 criteria we have that we use now really don't describe ADHD that well. They describe hyperactivity in children. And they're, again, because they're for researchers, all the criteria had to be things that they could see with their own eyes and count so that they could do statistics. And so all the criteria are overt behavioral symptoms. And so it doesn't capture at all what's going on the inside with how many thoughts you have, how much impulsivity you have, your difficulty with turning off your mind so you can go to sleep. All these things that actually are more impairing to people with ADHD, but which have been intentionally ignored until very recently in Europe. Um, we have to have, that's why chapter 2 is on the recognition of ADHD. Having it, what things should make it come on your radar? What makes it, uh, uh, just a quick digression because we're running out of time. One of my last publications, I'm the lead author, and I did less than anybody else on the study, but I won a bet. Uh, the study was on where they had 60 adults, uh, probably had ADHD, and they videotaped from going to the office into the psychiatrist's office, having everything that they talked about all the way back to the waiting room. And the goal was, what was it in the doctor-patient interaction that made the doctor think, just consider the possibility of ADHD? And I bet the rest of the people said, look, we're not going to have any data because the average American psychiatrist is never going to think of ADHD. It's not going to happen in 65 patients. And that's exactly what happened. Not a single one of them. In fact, 2 patients got so frustrated with the doctor, they said, look, they broke the line and said, this is a study of adult ADHD. That's all I've got. I don't have anything else. Most doctors, when they were being told the diagnosis, told them, no, you don't have ADHD, you've got bipolar. I mean, you didn't even say you have bipolar and ADHD. No, you do not have ADHD. So most psychiatrists in the United States are trained to never diagnose ADHD, to fight against it. So we got a long, long way to go.
Mm.
Most docs, one, wouldn't even think of it. And if somebody comes in telling them the diagnosis, they will disregard it.
I want to ask you about 2 things there. Rating scales. We were talking about rating scales. Here in the UK, we use the DIVA, the Diagnostic Interview in Adults. Sandra Kush, you mentioned earlier. What's your thoughts on that? And also, I wanted to ask about rating scale specifically for emotional dysregulation, if there is any that you can recommend for us clinicians, or RSD for that
Well,
matter as well. Yeah.
the DIVA is designed to give you a diagnosis of adult ADHD by asking the childhood criteria in mind-numbing detail. It takes me about, what, 2 hours to do a DIVA? And all you get is, do they meet childhood criteria or not? And have you met him ever since childhood? That's what it is. Again, it's another childhood scale. So it's the best at doing what it does. It's just once the person's past the age of 12, its answers are usually useless. It's basically saying, yes, this person had severe ADHD as a child, and some things have continued into adulthood. It's a research scale, again, based on white elementary school age boys who are hyperactive. That's who it picks up. So that, to my knowledge, there's not a good scale that is not based on the primitive childhood criteria. I don't know of one. I also don't know of one that does a good job screening for emotional dysregulation. Um, they're very general, and most of them are oriented toward loss of emotional control in all psychiatric conditions, not specified to ADHD. So I really don't have anything to offer.
So
Again, because people don't
literally,
know what to ask for.
So you can't diagnose emotional dysregulation separately. It's seen in the context of ADHD. Is that what you're saying?
You need to do both. How much of this is just difficulty controlling emotions? Because people with ADHD, their emotions are much bigger and much more difficult to handle. It's not that the person's deficit, which is Barclay's idea, the person's deficit, it's that the emotions are so overwhelming. Because what you do is when you find something that helps a person sort of turn down the volume on their emotional life to back where it's the same as a neurotypical person, you don't find that they're deficit. They're perfectly good at handling it. It's that their emotions are so intense. We have the problem with rejection sensitivity. Those emotions are normal emotions. They're triggered, they're instantaneous, they match the trigger. They're exactly like anybody else's emotions. It's just that they're overwhelmingly severe. In fact, that's the meaning of the word dysphoria. It's literally Greek for difficult to bear. The guys at Harvard who coined that term wanted to get right up in the name. The biggest feature was these are overwhelming, unbearable emotions. And then, it being Harvard, they put it in Greek so nobody can understand that. That's Harvard, you know.
Yeah.
So again, it's the intensity. It's not, again, research up to now has looked for a defective person, and they've gotten nowhere. They need to look at what people with ADHD do exceptionally well and what they have to contend with. We have hung to the executive function deficit theory for at least 25 years. I mean, it's really kept any new ideas from being put forward. And we've hung to it even though less than half of people with ADHD have a detectable learning executive function deficit, less than half. And yet the researchers want to say that is what ADHD is, even though less than half of people have it. That just seems ridiculous to me.
Dr. Dobson, absolute pleasure speaking with you today. You've shared so much. I'm just fascinated to
Wander
listen
around,
to you
didn't we?
We went all over the places, but we managed to get through everything I wanted to ask you, which is great. So that's absolutely good. And I'm sure our listeners have found it really useful. Your advice, your wisdom, your everything that we were discussing today, and all the topics that we've covered. If anyone wants to find out more about your work, certainly the book we talked about, it's coming out just around the kind of Thanksgiving time of this year. Anyone who wants to connect with you, where can they find out? Have you got a website or are you on social media? People can reach out to you.
No, I'm not on. I don't have a personal promotional website. What we do have is a somewhat primitive website for the book itself. where people can go and they can put their name on a list so that we will notify them when the book comes out. And the address of that website is Dodson, Dodson, ADHDtreatment.com.
Perfect.
And there we also post um, other things on there. Stuff we actually wrote for the book and now have no place to put it, so they are posted up there. And then
Mhm.
there's one section that's for clinicians only. With clinicians there, they can go and look at it. And it's all of the forms and patient education things and stuff like that that I developed over the last 45 years so that clinicians don't have to start over from scratch the way I did. But it's for
Brilliant.
clinicians only, because the last thing in the world we want is to have patients go in there and try and use that stuff to treat their own condition. That always ends in disaster. So there's one thing, just information about the book, and there's another small session that's for clinicians only.
Excellent. And yeah, so the website once again is Dodson, Dodson, ADHDtreatment.com.
Yes, sir.
Excellent. Perfect. So we'll post that on our podcast description when we eventually release the podcast episode itself. Just before you go, because we have our social media, we want to obviously promote this episode on our social media to let people know that.
Okay. I'm looking
Excellent.
forward to getting the book out. I've been working on this on and off for 20 years.
Wow. So
Uh,
yeah,
this is actually the sixth complete rewrite because I keep learning stuff.
right.
So my children say there's the fourth child in the family that they have to
Really.
contend with.
Yeah, and that child is getting all the attention at the moment.
Yes. So I'm 75 and I've got to get this book out there before I croak or have a stroke or something like that. So I got to finish.
And it's good time to release it as well. As you said, you're the keynote speaker at this year's international
Uh,
conference on ADHD in Kansas City. So yeah, that's perfect timing. So
yeah.
that should attract a lot of interest.
Yeah. So
Yeah, perfect.
this, are you familiar with Attitude website?
Yes, I am. Yeah,
Okay.
yeah, yeah, I am. Yeah.
Well, last month was their 25th anniversary. And so the editors chose the 25 most influential articles in their 25-year history. I had three articles. One person had two, and everybody else had one. And one of my articles was the single most influential article of that 25 years. And it's entitled The Three Things About ADHD That Usually Get Missed. And it's the interest-based nervous system, emotional dysregulation and ADHD, that sort of thing. So that was considered the most influential article they ever published.
Wow.
And the number, like 17th, was on rejection sensitivity dysphoria. So it's
Yeah.
If you look at that stuff in the research literature, it's totally absent. Not there. I can't. I've tried, cannot get anything even considered. The last paper I submitted on a Sunday afternoon at 2 o'clock, when I checked back at 3, had already been um, rejected. It wasn't even like, you can make these changes. No, they were not going to publish anything about RSD, period. This was a Journal of Attention Disorders, which is the journal. They are not going to mention it. So obviously, whoever was, you know, online at the time doing the reviews didn't even have time to read it. They saw the subject and immediately refused it permanently. So
Yeah. Shocking.
so I've given up trying to publish in the scientific literature. They just aren't going to do it, even though the stuff that I put forward by everybody else is considered to be pretty good. So
Yeah.
that's what this book is to pull it all together. And so you get to do what you will.
Yeah. Yeah. No, I'm sure it's definitely gonna be very useful for us practitioners Even, we have experience, but I think we can only use what we have, what's already out there. So
Yeah.
it's nice to have something else that's going to come onto the market that can give you different perspective, certainly, from yourself with your only perspective experience of having worked with a lot of patients over the years. So yeah, I look forward to. Have you been to the UK before at all?
No, my co-author is in Oxford,
Okay,
Dr. Alison Perry. She's a neurologist there
okay,
on faculty. Absolutely brilliant, real out of the box thinker. So that's another thing where this book is going to be new, is that it's not just psychiatry, it's also approaching it as brain-based neurologic. And in particular, the fact that ADHD is found much more frequently in a lot of medical conditions that have no good treatment. Chronic fatigue syndrome, um, migraines, pseudo seizures,
seizures.
hypermobility syndromes, um, fibromyalgia was the one I couldn't come up with. Again, very common conditions that really don't have good treatments. And it turns out that all of them have ADHD at least 40% of the time.
Wow.
Eating disorders have
Yeah.
ADHD 40% of the time. And that when you treat the ADHD, which is wonderful treatments, people don't get well from their functional neurologic condition, but their life just gets so much better. So that's
Yeah.
something that's brand new. If you look in the European, it's not in the American literature at all, it's in the European literature, which American doctors do not read. There are a lot of people who are making these connections now on the illness where they're a specialist. So somebody with hypermobility syndromes notes that ADHD is there very commonly, and when you treat the ADHD, things get better. And so what she's doing is she's putting it all together in one chapter where
Yeah.
people can get an introduction to it and see that this is a pattern. So there's a lot of groundbreaking stuff.
Yeah. Hypertension is another one. I see a lot of patients with
You know,
hypertension.
and
Yeah.
POTS.
And
About
POTS. Yeah.
and
Yeah.
about 50% of people with POTS
Mm.
will have ADHD as well.
Yeah. Yeah.
So ADHD is very sneaky.
Mm.
If you look for it, you'll find it everywhere.
Yeah.
But
Yeah.
you have to think of it, and most people don't. So,
So
well,
yeah, I
it's
know.
been a
I'll let
pleasure
you go.
talking with you.
Absolute honor to speak to you as well. So
Uh,
yeah, I look forward to meeting you in person at the conference in Kansas City. I think we can reconnect as well at the conference or nearer
yeah,
the when your book is out, if you want
yeah,
to come on and just focus specifically on the book once it's
that would
released
be
as well. We
great.
can do that. Yeah, yeah.
Wonderful. Yeah.
Excellent.
Maybe we get together a month in advance. Maybe have dinner or breakfast together or something like that.
Absolutely. Yeah, yeah, that will be good. That will be amazing.
Uh,
I look forward to that.
okay.
Excellent, Bill. Take
nice,
care.
nice to meet you. Nice,
Nice
Archie.
to meet you too. Take care. See you later. Bye.
Bye bye.
Bye bye.